Okay, good morning. I'm going to present a trial entitled ROSCE about cessation of TKI, tyrosine kinase inhibitors treatment in CML patients with deep molecular response. So, probably you know that stopping treatment is an emerging goal of chronic myeloid leukemia management, because several studies have already demonstrated the possibility to stop treatment. We did in Lancet Oncology already 6 years ago, confirmed by Australian group, confirmed also by the French group, and recently we reported the STEAM study with a long follow-up which validates the concept of treatment-free remission. So a sustained deep molecular response on long-term TKI therapy seems to be necessary prior to attempt treatment-free remission. However, the more precise conditions for stopping CML treatment are not yet well defined. So already 4 years ago we start a trial in Europe entitled ROSCE. The criteria of stopping treatment were less strict as compared to the previous study. In another word, patients were proposed for stopping when they were in deep molecular response defined by MR4. In another word, it means that the BCR-ABL level is at 4 log reduction as compared to the beginning of the disease. This deep molecular response is sustained during 1 year, and the patient have to be treated in 3 years, and every kind of TKI were possible in that study. And the definition of molecular recurrence or molecular relapse in that study was loss of major molecular response. In other words, a level of BCR-ABL more than 0.1%. We include, or we have pre-registered in that study more than 800 patients. 11 countries from Europe participate to that study. So here you have the different patient or the patient flow and disposition. So the final registration was 821 because we have some screen failure, and because some also exclusion and different protocol violation, the analysis was performed on 758 patients. And we have also proposed prognostic modeling on 448 patients only treated with imatinib de novo. So we perform an intention to stop treatment analysis among the 755 patients. So among them, 373 patients lost the major molecular response. We observed 4 deaths, and the median follow-up, but the median follow-up was around 15 months, and the median follow-up for the patient who did not relapse was 26 months. As you can see on that curve, most of events, in other words, most of loss of MMR occurred during the first 6 months. The probability to be off treatment still in major molecular response at 12 months is 55%, and it is 50% at 24 months. So with inclusion and relapse criteria less strict than in many previous trials, and with a decentralized but standardized PCR monitoring, stopping of TKI therapy in a large cohort of CML patients appear feasible and safe. This trial, close to the true life, demonstrates that half of the patients are still off treatment without molecular recurrence, with a median follow-up around 15 months. The proportion of patients without recurrence loss of MMR after 6 months is 51%, and after 18 months is 52%. longer duration of imatinib therapy prior to TKI stop correlate with a higher probability of relapse-free survival. And it is really the only factor that we observed. In addition, the duration of MR4 is also significant, and on Monday I will present a cutoff for the duration of MR4, because the cutoff of duration for imatinib therapy in that study was evaluated at 5.8 years. Gender, age, or any other variables such as UTOS so-called score are not able to predict the success of stopping treatment. And we think that our study will be very useful and supports to edit new ELN recommendations. So I want to thank all of my colleagues in Europe, and particularly Suzanne Sossele, which is on the first row here, which is my co-PI. Thank you very much.